Hello students, this is Dr. Turpin. We're going to talk a little bit about non-infectious lower respiratory problems. Patients really that have problems with lower airway disorders usually have significant problems with oxygenation, ventilation, and gas exchange. And as a result have complications that come from those disorders. And a lot of times lower airway disorders can be chronic and then they progressively get worse and worse. So it's not always a great diagnosis for someone to be told that they have one of these type of diseases, because it often means that each day is the best day moving towards a worse day, and coming to grips with that is sometimes difficult for many patients to accept. So asthma, in terms of its etiology, it affects 17 million Americans. 5 million of those are children. So 8% of children are affected and 7% of adults have asthma. And it is more common in women than in men, and slightly more prevalent among African Americans and Caucasians. And even though some of the things have been targeted at decreasing smoking and improvements in work conditions that might have placed people in factories or areas where they might have had more air pollution that might trigger some of this asthma, the number of people with asthma is still continuing to grow. Risk factors for asthma include a family history, if a person has been diagnosed with eczema, because it is sort of a reactionary disease as well, and the presence of allergies such as rhinitis or inflammation in the sinus passages tend to go hand in hand with asthma. Different types will have attacks that are triggered in different ways, but you hear people talk a lot about with asthma patients what are their triggers. So it can be caused by specific things that they're allergic to, and when they come in contact with that, it can be just something that they smelled or inhaled that was irritating. Sometimes it can be caused by microorganisms, where they have a minor infection. And aspirin has been associated with causing asthma as well. Some patients will also have a type of asthma that's considered hyperresponsiveness, and it can be brought on by exercise, a severe infection, and then some patients just have they're not able to ascertain what their actual triggers are because they kind of vary, and so those are even more difficult to manage. Asthma is a condition that occurs intermittently and is reversible. So you have an asthma attack and the patient does recover from it, and it can occur in two different ways. It can be from inflammation, and when you think about the inner diameter opening in the airways, if you get an infection or you get an irritant that creates inflammation on the inner wall of that, it inflames and it, gets more edematous and swells, making the airway, less open and making that diameter shrink to a certain degree. And then also from an airway standpoint with asthma, you have hyper-responsiveness of the smooth muscles on the bronchial tubes that can cause what's called bronchoconstriction, meaning that the muscles that literally around there constrict. So now you have inflammation occluding the airway somewhat on the inside, and then you have an external force of the smooth muscle causing bronchoconstriction, and so now we've got two problems that are going on. So Some patients may present with just the inflammation. Some patients might present with just the hyperresponsiveness, but often the worst case scenario is when you have both things going on at once, making it even worse. Because again, with two things going on, you can have even more severe occlusion of that airway. So when someone has exposure to their trigger, it leads to wheezing, dyspnea, coughing. They can have increased sputum, and of course an increased respiratory rate. And so how do we diagnose this? You're going to get a history from the patient. They will do one of the key studies that's involved in a pulmonary functions test that's called a forced expiratory volume in 1 second. And they're looking to see how well can the person breathe air out forcefully. And that gives them an idea of how much pressure in terms of airway flow that they have. Obviously, they will do chest x-rays, and of course that's looking at the condition, but also looking at what do the lower lungs look like? Do they have some type of an infiltrate or something that looks like an infectious process that's going on at the same time? We always put these patients immediately on pulse oximetry to get an idea of their oxygen saturation, and usually do blood gases, arterial blood gases, which we've already talked a little bit about and the painful nature of that. Treatment is going to be assessment, monitoring, control of environmental factors, that reduce their exposure to the triggers. So if someone has a allergic reaction to dog hair, then they're probably not going to be able to have a dog. Or they've got to do some other ways of preventing exposure to these different triggers. Some families have found when they move their family of young children into, say, a rental home, there may be environmental conditions that are in a home that they don't technically own, and then they're under a lease and a contract, and their family members who have asthma may be suffering greatly. They'll try cleaning, they'll try vacuuming, they'll try doing different things to kind of improve that environment, but sometimes it's difficult for them to always extricate themselves from the trigger environment. Again, there's other pharmacological treatment, and then educating people how to manage their disease. So this is kind of collaborative management when you talk about it. Manifestations, you're going to be able to hear an audible wheeze and an increased respiratory rate on these patients when they come in the middle of an asthma attack. Again, they may have increased cough, some sputum production. They may, depending on the severity of the condition, they may be using accessory muscles. And when you see patients that are literally pulling their chest in with every breath, trying to get air to come in because they can't get air in because of the tiny circumference of the bronchial tubes where they're constricted, that they are in a very bad way at that standpoint, and you really need to be getting ready to intubate somebody or getting the doctor there ASAP. Of course, you can give bronchodilators, is considered a rescue medication, and we'll talk more about that. But just know when you get to the point where you're seeing respiratory rate and then accessory muscle use, this will go on for a period of time. As the person wears out, then you may see less alertness, more cyanoses, hypoxemia, and you may finally, if they are really not oxygenating, you may see their respiratory rate decrease quite a bit. So, you think about increased rate with asthma, and you think about straining to breathe and wheezing, but if somebody's been going at it so long without relief that now they're getting sort of out of it and the respiratory rate decreases, that is definitely not a good thing. So important to remember that, because if you see that change of a condition, it's not going to be long that they have the potential to not be moving air at all. So wheezing versus stridor, this just kind of is an explanation of kind of how you sort out, when is one thing versus the other. So I won't read all that to you, but make sure that you review that. We talked a little bit about stridor already, in the sense that, patients do have that with airway, upper airway concerns. Sometimes it's a foreign body, or other things that may cause a severe inflammation or edema that's cutting off their upper airway. Wheezing has a little different sound to it, and for your asthma patients, and some COPD patients will wheeze like this as well. You sometimes with a bad one, you don't even have to auscultate their lungs, because you can hear them from the door when you walk in wheezing. So it's just a good idea to kind of pay attention to know the difference between these two. So we've already talked about blood gases. Arterial O2 may decrease in an acute asthma attack, and that can be from hypoxia. Arterial CO2 may decrease early in an attack, but then it really, the worse the gas exchange is, you will see that go up much higher. If it's an allergic asthma, they may have an elevated serum eosinophil count, or immunoglobulin E levels that are elevated. And sputum cultures a lot of times will show eosinophils, mucus plugs, with shed epithelial cells. And so just some key things you might find on laboratory assessment. I'd already mentioned a little bit about pulmonary functions test. This is just a slide that gives you a little bit more information. We do usually have asthma patients go home with a peak expiratory flow rate apparatus, so that they can kind of self-monitor their disease. And when they do the peak expiratory flow, it will tell you if you're in the green zone, the yellow zone, or the red zone. And if you're in the red zone, you need to be getting 911, getting somewhere, because your flow in terms of the ability to move air is significantly decreased. So patients really pay attention to that who manage their disease well. Is it improving? Is it getting better? Am I having a downfall? I've had some congestion. They might contact their doctor when they're in the yellow zone if they're having more bad days, and get evaluated before they get to the point where they're in the red zone, where it's not reading that airflow is really effective. So we teach the patients how to self-manage, and usually teach them about peak flows, get them one of the apparatuses to take home with them. We go over their medication therapy plan, talk to them a little bit about staying active, but maybe not to the excess, and then really getting an idea of what are the triggers for these individuals that cause that, and best come up with plans to avoid them. And then, last of all, rapid treatment for status asthmaticus, which is the most severe reaction in an asthma attack. So drug therapy for asthma is based on severity, in the category of how severe it is. There are controller drugs that people take that are more like long-acting bronchodilators. They might be on corticosteroid inhalers, and your long-acting